السلام عليكم طلابنا الأعزاء طلاب المرحلة الخامسة. محاضرتنا راح تكون آخر محاضرة about the nasal diseases and it is about the sinonasal tumors. Objective of this lecture is to throw a light on the classification and the management of sinonasal tumors. Sinonasal tumors are classified either as a benign or malignant tumors, and each one is divided into either epithelial and non-epithelial tumors according to the tissue of origin. The benign tumors, the epithelial benign tumors such as the papilloma, the non-epithelial benign tumors which arise from the non-epithelial tissue such as the osteoma arising from the bony tissue, angioma arising from the vascular tissue, chondroma arising from the cartilaginous tissue, and fibroma arising from fibrous tissue. The malignant tumors, epithelial, the most important and common sinonasal malignant tumor is the squamous cell carcinoma. Other includes the adenocarcinoma, malignant melanoma, and adenoid cystic carcinoma, which arise from the adenoid cystic carcinoma arises from the minor salivary glands. The non-epithelial tumors such as the fibrosarcoma, osteosarcoma, angiosarcoma, rhabdomyosarcoma, which arise from muscular tissue, and lymphoma. First, we take the important tumors, starting with the benign epithelial tumor, and we are going to talk about the inverted papilloma, or what is called the Chanderian papilloma, which is the most common benign tumor of the nose and paranasal sinuses, and usually arise in middle age and almost exclusively arising from the lateral nasal wall. Most of the masses inside the nose arising from the lateral nasal wall, and may extend into the maxillary and the ethmoidal sinuses. Pathology: the tumor is covered by inverted mucosal surfaces extending into the stroma, so the name inverted papilloma. Clinically, as it is a tumor, so it will cause, there is a unilateral mass causing unilateral nasal obstruction and unilateral rhinorrhea with sometimes epistaxis, more common in male than female, about a 3:1 male to female ratio, and over 50 years of age. Examination shows mass in the nasal cavity by anterior rhinoscopy, of course, and endoscopic examination shows a fleshy mass. The diagnosis is by one first doing a CT scan. Opacity of the maxillary sinus could be seen, and could extend this opacity to the ethmoid sinus and nasal cavity. This is because it arises from the lateral nasal wall, which is actually the medial wall of the maxillary sinus. So the tumor may extend to the maxillary sinus and cause the opacity of the maxillary sinus, and to the nose, causing opacity of the nose of the lateral nasal cavity, and also extend to the ethmoid and causing opacity of the ethmoid sinus, and thinning of the bone. But usually there is no frank erosion because, as we said, it is a benign tumor. Histopathology is done in order to exclude malignancy. However, malignant changes may occur in about 2 to 10% of patients with inverted papilloma. The treatment is by wide excision endoscopically, either endoscopically or external approach to avoid recurrence. This picture showing by inspection there is mass filling the right nasal cavity and extended to the right anterior nares, and also cause widening of the right LA, which means that the tumor is a large tumor. This is a CT scan showing isodense lesion which involve the right maxillary sinus with extension into the right nasal cavity and pushing the septum, and also involvement of part of the ethmoidal, right ethmoidal air cells. For the benign non-epithelial tumors, we are talking about the osteoma, which is a slowly growing tumor, and it is often occurs in young adult and mostly in the frontal sinuses. Usually they are asymptomatic and found incidentally by doing a routine radiographs for another reason. For example, patient presented with features such as sinusitis, and we are doing the plain X-ray for acute sinusitis, and we discovered the presence of osteoma. When the osteoma become large, it may cause headache. The diagnosis is by radiology, and the treatment is by surgical removal of the osteoma is symptomatic. If it is symptomless, then only follow-up and no surgical resection is required. This is a plain X-ray occipital view showing, of course, there is a radio-opaque lesion in the frontal sinus unilaterally, and this is a frontal osteoma. This is a CT scan axial view, also show there is a hyperdense lesion in the frontal sinus, and actually this hyperdense lesion, it is a bony lesion, and it is a frontal osteoma. Note the frontal sinus are asymmetrically separated by a septum, and also note the scalloping of the frontal sinus wall. مثل ما نشوف انه الساينس وول نوت سموث بمثل تعرجات، هذه ما تسمى بالسكالوبينج. Now we finish the benign tumors and we come to the malignant epithelial tumors. As we said, epithelial tumors could include squamous cell carcinoma, which is the commonest malignant tumor of the nose and paranasal sinuses, and it is used to be seen in those who work in nickel industries. The adenocarcinoma, it arises from the glands in the upper respiratory tract mucosa, and it is more seen in workers who work in the hardwood industries. Adenocystic carcinoma, as we said, arising from minor salivary gland in the nose and paranasal sinuses, and malignant melanoma, which arises from the melanocytes, and they appear as a dark or pale sessile mass on the nasal septum or lateral nasal wall. So the melanoma from the tumors that may arise from the medial nasal wall. And as we said, most of the malignant tumors of the nose are arising from the lateral nasal wall. But the melanoma may arise in the medial nasal wall, which is the nasal septum. The malignant epithelial tumors such as sarcoma, various types of sarcoma, fibrosarcoma, osteosarcoma, chondrosarcoma, rhabdomyosarcoma, and the types of lymphoma such as Burkitt's lymphoma. The size of malignant tumor, the 80% of the malignancy of the sinonasal malignancies are squamous cell carcinoma. 60% of the tumors arising in the maxillary sinus, and 30% in the nose, and 10% in the ethmoid. While the tumors of the frontal and sphenoidal sinuses are fortunately rare. So the most common site of malignant sinonasal tumor is the maxillary sinus, which constitute about 60%. For the etiology, smoking play a role. Also, as we said, nickel exposure will predispose to squamous cell carcinoma. Hardwood exposure, which predispose to adenocarcinoma. Human papilloma virus, which can predispose to inverted papilloma, which is actually a benign tumor, but in 2 to 10% it may change to malignancy. Clinical features of malignant sinonasal tumors. The tumors, those we divide the features whether the tumors arising from the nose or frontal sinus, or the sphenoid sinus, or the ethmoid sinus, or the maxillary sinus. For the tumors arising from the nose, actually they will cause nasal features, which include unilateral nasal obstruction, unilateral epistaxis, unilateral nasal mass, and maybe hyposmia. The frontal sinus tumors, because the frontal sinus is closely related to the orbit, because it forms the roof of the orbit, so it will cause orbital features, which include proptosis, diplopia, and blindness. Sphenoidal sinus tumors, these are situated below the sella turcica, so they may cause neurological features. Ethmoidal sinus tumors, actually because of their position, which is medial to the eye and close to the nose, so they may cause nasal and orbital features. Maxillary sinus tumors, clinical feature divided into either early features and late features. The early features occur when the tumor is still confined inside the sinus cavity, and the features will be the same as of chronic sinusitis, such as headache, nasal obstruction, postnasal drip. These are the early feature, and the tumor is still inside the maxillary sinus. But the late features occur when the tumor spread outside the sinus cavity and leading to the features according to the site of the invasion. The maxillary sinus, if it invade the anterior sinus wall, which means that it will pass anterolaterally into the anterior sinus wall, anterolateral sinus wall, and then will pass to the cheek. So it may cause cheek swelling, ulceration of the cheek, involvement of the infraorbital nerve, because the infraorbital nerve cross in front of the anterior maxillary sinus wall, and this will cause facial pain and paresthesia. If it pass not anterolaterally, pass superiorly, means that the superior wall of the maxillary sinus is the floor of the orbit. So it will cause orbital features which include proptosis, epiphoria due to the damage of the nasolacrimal duct, also blindness to the invasion of the optic nerve, diplopia due to limitation of the movement of the eyeball, or external ophthalmoplegia due to paralysis of the extraocular muscles. If it pass to the medial wall, which actually medial wall of the maxillary sinus is the lateral wall of the nose, so it will pass to the nasal cavity. So it will cause unilateral nasal mass, appear by anterior rhinoscopy, unilateral nasal obstruction, recurrent epistaxis, and maybe anosmia. Invasion, if it pass posteriorly, it will pass invade the posterior wall of maxillary sinus. So posterior to the posterior wall of maxillary sinus, there are the infratemporal and pterygopalatine foci. So it will cause trismus, which is the inability to open the mouth due to the invasion of the masticatory muscles. Also facial pain and paresthesia due to the involvement of the fifth cranial nerve, the trigeminal nerve. If it invade the inferior wall, actually the inferior wall of maxillary sinus is the hard palate, so it will pass to the mouth, so it will lead to loosening of the teeth, ulceration of the palate, which cause later on may cause oroenteral fistula and also dental pain. The intracranial spread, when it spread intracranially, actually will cause features of increased cranial pressure such as headache, vomiting, and other neurological features. Lymph node metastasis in sinonasal malignancy is fortunately not of high incidence, about 10 to 50 to 15%. The systemic metastasis is also fortunately occasionally seen. This picture shows sinonasal tumor involving the orbit, and also there is edema of the cheek on the left side, on the right side. Investigation when patient presented with nasal mass, general blood investigation actually such as a complete blood picture, ESR, renal function test as a preoperative measure and to detect the distant metastasis. CT scan MRI will show the tumor and also show the bone erosion and the extension of the tumor. And the definitive diagnosis is by taking biopsy. This CT scan coronal view showing the mass involving the isodense lesion involving the maxillary sinus, and actually when the arrow there is erosion of the skull, anterior skull base. Treatment, usually the treatment of carcinoma, of the sinonasal carcinoma is surgery and chemoradiotherapy. There are three main surgical options for carcinoma, treatment of the carcinoma. Either medial maxillectomy, which means that removal of the medial wall of the maxillary sinus, which is the lateral wall of the nose, or total maxillectomy, which means removal of the maxilla as a bony box, and the craniofacial resection, which is used when there is involvement of the cribriform plate. Generally, an orbital exenteration is indicated only if the tumor breach the periosteum and involve the orbital fat. When there is involvement of the orbit and there is no involvement of the orbital fat, then we can preserve the orbit. But when the tumor breach the periosteum and involve the orbital fat, then we need to do orbital exenteration, of course. Follow-up and aftercare. As any tumor, the follow-up should be monthly for the first post-operative year, and bi-monthly for the second post-operative year, and every 3 months for the third post-operative year, and then every 6 months for the fourth and fifth post-operative year, and then annually for a further 5 years. So the follow-up will be for 10 years. A prognosis, the overall 5-year survival is about 30 to 50% in squamous cell carcinoma and 45 to 60% in adenocarcinoma. So the prognosis for adenocarcinoma is slightly better than for squamous cell carcinoma.